give you an overview about Blackpool. If you don't know Blackpool, it is a very busy hospital covering three big part of the hospital, such as the Blackpool, Files and Wire, and it is part of the Lancashire and South Cumbria Integrated Care Service. It has got three hospitals, the Blackpool Victoria Hospital, which is the primary site for A&E, maternity, and comprehensive acute services. The Clifton Hospital offers inpatient rehabilitation and specialized care services. And the Blackpool Hospital, which is a community hospital serving the Wire. Blackpool Teaching Hospitals operate 830 beds across all three sites, with the main Blackpool Victoria Hospital operating 767 beds, including 13 beds in critical care. And during winter, when there's a surge of viral infection and winter diarrheas, we operate up to 793 acute beds. That is including the surge beds. As you can imagine, the business of Blackpool Teaching Hospital, covering 80,000 to 900,000 cases that comes to visit Blackpool because of their very nice seashore. So roughly 220 to 250 patients every day are being seen in ED and urgent care. And during winter, when C. diff norovirus and winter respiratory viruses are rife, of course, the hospital is very, very busy. And this is just to show you, actually, the hospital is very busy. Obviously, it aligns with how the lab works, and it's very busy, as you can see. This is the total of diarrhea samples that they have tested in 2025. This is including primary care and GP. So please don't take us, we have a lot of C. diff and norovirus there, okay? But this is just to show you how lab work constantly to ensure all diarrhea patients are tested in a timely manner. So why did the lab change methods in Blackpool Teaching Hospital? So as you remember, I don't know how long you've been on IPC, you remember about culture, yeah? Where it gives you lengthy time to wait for the result. It can take 72 hours, isn't it, to wait for a result of Salmonella, Shigella, or Campylobacter, or E. coli. And if that's negative, then you will send for ELISA test. Then you have to wait for another 24, 48 hours. And that actually makes IPC not efficient because we have to wait for 5 days for the result to be available so that we will action IPC in a timely manner, and not just diarrhea cases, but also other infections. Because obviously, we have to ensure that all patients with infections are placed in a timely manner. So the modular PCR, as you are aware, again, this gives a multiplex test for different types of organisms, such as bacteria, viruses, and parasites, which will give you results within 1 to 4 hours, which significantly faster than traditional culture method that takes days. Very busy slide. But this is a diagram that's taken from UKHSA in 2024. And this guideline recommends testing for a broad range of pathogens which have traditionally required a triage approach to testing to reduce cost and burden on the lab. The testing algorithm for acute gastroenteritis in a hospital setting focuses on rapid identification of pathogens to manage outbreak and guide appropriate treatment, while reserving tests for specific high-risk cases to optimize resources. The current standard of care increasingly relies on molecular multiplex polymerase chain reaction, or the PCR, as we all know, which allows a rapid simultaneous detection of multiple pathogens from a single stool sample. Again, this is from UKHSA, issued in 2024, just to show you how lab worked enormously to ensure patients with persistent diarrhea, blood mucus or pus in their stool, patients who are systematically unwell, who had history of previous hospitalization, history of antibiotic intake, immunosuppression, and travel within 14 days prior to the onset of symptoms of diarrhea are tested. So this, you can see there, 12,000 samples per year is enormous. And that gives a lot of pressure onto lab resources and ensuring we get the result in timely manner so that IP measures are in place. Again, another busy slide. So prior to 2022, the lab scientists would advise bench of appropriate tests to perform on each individual samples based on requests from the ward clinician. Based on those results, additional tests may be required. And the test takes approximately 4.5 to 5 hours to complete, with 2 complete runs within 8-hour shifts. Up to 4 to 8 samples can be run in a single batch. Data from November 2020 with traditional methods were employed versus December 2022 when PCR was employed. A higher than average turnaround is about seen on Friday to Saturday with traditional methods, whereas PCR remains constant all the week. So if you can see how efficient genetic signatures tests can actually provide trust, because the average inpatient turnaround time from Monday to Sunday since December 2022 was 0.64 days. And if you divide that, that is actually 15 hours only, compared to waiting for 72 hours maximum for just testing for bacteria. And if it's negative, you have to send for another test for virus or vine parasite. So, appraisal of testing strategies pre-2022 at Blackpool Teaching Hospital, I told you already. We have used a combination of culture, ELISA, and modular PCR. It has got a lot of challenges that have implicated in the performance of the lab to ensure that testing is done in a timely manner so that IP measures are advised in a timely manner. Of course, there's complexity of implementing algorithm in laboratory, reliant on adequate provision of clinical details for supplementary tests, overall low yield due to low sensitivity and narrow spectrum of pathogen cover. Patient status may change from community to inpatient. And consequently, there's increase in batching and increased turnaround time. There's missed or delayed diagnosis. There's low cost effectiveness. And there's always a duplication and delay in testing. These are the organisms that can be tested just for one stool sample. You could just imagine. It will give you all these results less than a day. This we have used post-2022, and it has helped us a lot with our patient flow. This is just to show you, following on that slide, how quick the tests can give you results. Compared to PCR and culture, which will give you 3.26, which is average 75 to 90 hours, compared to 0.89, which is actually very, very efficient, because you will have the result less than a day. And the syndromic testing paradigm, as you can see, it has got, it cut down a lot of arrows or pathway wherein these samples are being distributed to different benches on the lab to be tested. So, why did I call my talk Better Test, Better Flow? As you can see there, the conventional testing diagram, as I've said earlier on, you have to triage. Is it viral or bacterial? Then you wait for the report. Then you have to send for testing for another if those are negative. While the syndromic testing paradigm, very simple. Universal sample prep, multiple targets across viral, bacterial, and parasitic pathogens, faster actions across all syndromic panels, 100% samples, one actionable test. So what? Better flow. How did we do it? So if a patient develops diarrhea or they come via A&E, we put them straight away in a side room. Okay? We institute IPC measures, good hand hygiene, appropriate use of PPE, not just appropriate use, but disposal of PPE, and a stool sample. While waiting for the medic to assess the patient, the sample is running in the lab, okay, getting ready to be cooked. Then you will get the result less than a day. So this, for me, is improved patient management. So patients' admission management, as I have said, I'm sure you all know diarrhea, Bristol stool chart 5 to 7, and more than 2 to 3 episodes a day. We test with pan-enteric detection kit. At this point, symptomatic patients are placed appropriately in the side room with all IPC measures in place. Of the 24 pathogens that I've shown you earlier on, why am I interested with C. diff and norovirus? I'm sure you know the answer. So, UKHSA monitors C. diff, as we are all aware, we all have targets, because it is the leading cause of healthcare-associated diarrhea, and that can cause significant morbidity and mortality, particularly among elderly and immunocompromised patients. It is also designated as an urgent threat due to high recurrence rate, increasing resistance to standard antibiotics, and it significantly affects economic impact on the healthcare setting. The UKHSA epidemiological commentary in February 2026 states that Clostridium difficile infection have shifted to an upward trajectory since 2020 to 2021. contrasting patterns seen in early years of surveillance, as it increased by 33% between 2020 to 2021 and 2023 to 2024. This marks the highest overall case rate since 2011 to 2012, driven by recent increase in both hospital onset and community onset CDI cases. So that's C. diff. So why I'm interested in norovirus as well? Because norovirus, as you are aware, can cause big outbreaks in the hospital. It is reportable to the local Public Health England. Because it is very contagious, it has extremely low infectious dose, and it is remarkably stable in the environment. Unlike bacteria, norovirus can survive for a long period of time on surfaces, resist many common disinfectants, making it easy to spread in closed like hospitals, nursing homes, and cruises. Norovirus outbreaks are reportable because the virus is highly infectious, and it is more significantly infectious than Salmonella. That is why we focus on this organism. Okay, C. diff 206. No, actually, it's not. That's the whole Blackpool. We had 109 C. diff cases in 2025, 15% lower than last year. So what we've done to ensure that there's ascertainment of infection, as the previous speaker said, we followed the PSERF Patient Safety Investigation Response Framework. And we have devised a rapid review of cases, not just C. diff, but all reportable, UKHSA reportable cases. So we review C. diff within 24 to 48 hours when we get hold of positive result. We invite microbiologists, antibiotic pharmacists, clinicians looking after the patient, the ward manager, or the nurse in charge, or anyone who wants to learn how we investigate infection. And what we found so far, not all C. diff toxin, not all patients with C. diff toxin positive are true infection. As we look at their blood results, PCR is normal, WBC is normal, no other signs of infection. And when we look at the drug chart, guess what the patient had previously? Laxative, right? And when we found, as the nurse looking after the patient, and we asked, have you called doctor to review your patient? They said no. So why not? That's the question. Why not? Why are we nurses not working collaboratively with the medics? So, within 24 to 48 hours of our ICR review, we have found that some of our cases of C. diff toxin are actually not caused by infection, but laxative intake. So right there and then, we stop antibiotic. And this is actually an evidence that the trust can show that we have a very good AMS, antimicrobial stewardship, working alongside microbiology, the pharmacist, the consultant looking after the patient. And this as you are aware, can prevent AMR. So this is what we've done so far. I'm sure you all know. Very easy, right? Very easy to follow. So effective IPC improves patient outcomes by preventing infections that can cause longer stays in the hospital, serious illness or death, while also reducing antimicrobial resistance. So within the 24 to 48 hours of our CD4 round with the multidisciplinary team, we are also observing what we called antimicrobial stewardship, or the site. Suspect, isolate, you use your PPE, gown, good hand hygiene, and test. This protocol provides critical advantages in reducing morbidity and preventing transmission. It is well known that if there's increased incidence of infection on the ward, pressure in the system builds up as we speed up our work. Staff workflow accelerates to catch up with the work that has left behind because of these infections. This is when consistency of IPC best practice drops. So how did IPC ensures IPC compliance is sustained? I've got 2 IPC here in front of me. I told them, you go to the ward from 9 o'clock in the morning. You've assessed your patients. You have done your observations. You have observed how your cleaning contractors are cleaning the environment. You ensure the staff are not wearing gloves everywhere. Okay? Because environmental cleanliness, including enhanced cleaning of high-touch areas, can remove 32.5% reduction. I need to speed up. So norovirus again, we don't have 731. So in the last winter, I think we are quite lucky. We only have 16 outbreaks from January, and then it ended in March. That's the quickest the hospital has sustained patient flow because of the IPC measures that we have put in place. Same thing, we cohort, enhance cleaning, daily IPC audit, including hand hygiene, environmental cleanliness, bare below the elbow. Don't forget bare below the elbow because it facilitates effective hand hygiene. Intake and output as well, because your patient's already having diarrhea. You don't want them to have UTI, and then your patient will eventually have E. coli in the urine. And we continue IPC measures within 48 hours of free of symptoms. Negative results, hooray. IPC will not stop there, actually. We work collaboratively with a clinical pathway guru, like the gastro team, nutritionists, and we make sure that patients remain in the side room until it is required for another patient with infection. In summary, this is what I would like to emphasize. Multiplex fecal PCR offers turnaround time typically around 1 to 5 hours compared to conventional culture. This test enables faster diagnosis and faster initiation of appropriate targeted treatment because it can identify multiple pathogens in a single sample, revealing co-infections that are often overlooked. Rapid identification of pathogens allow for quicker implementation of IPC measures such as isolation, This limits outbreaks. By providing a rapid, comprehensive result, multiplex PCR can reduce the need for follow-up testing, such as imaging. It also aids in reducing the use of empiric antibiotic, guessing what to give to patients, by confirming is it viral or bacterial cause. This results in optimized patient care, better patient outcome, and of course, better patient flow. Thank you.